This video will be exploring the topic of community-oriented primary care in light of the Affordable Care Act in 2010. Our presentation is by Socorro Benavides, Chandani Poran, and Emily Powell.
Community-oriented primary care is a system in which primary care is used to identify and address community needs. It can be seen as the integration of public health practices and primary care services. The main mission of community-oriented primary care is to develop a system in which we can provide affordable community-based primary care. There are 5 principal elements, as defined by the World Health Organization, of community-oriented primary care. The first of which is reducing the exclusion and social disparities in health through universal coverage reforms, the organizing of health services around people's needs and expectations, integrating health into all sectors, pursuing collaborative models of policy dialogue, and increasing stakeholder participation. Community-oriented primary care was first introduced in South Africa and Jerusalem. Eventually, COPC was recognized as an important framework in America in 1982 through a conference organized by the Institute for Medicine. At this conference, practices utilizing COPC in the United States were reviewed. It was found that through the promotion of prevention and improvement of primary care using the COPC approach, there was an increase in health status and access to health care for selected populations, especially the underserved in those populations. This conference affirmed the effectiveness of the COPC approach, which then sparked major cities in the United States to target healthcare in this manner, including Dallas. Furthermore, COPC approaches were integrated into family medicine residency programs in the early 2000s. The Affordable Care Act, introduced in 2010, influences COPC by first allocating funding to facilitate the implementation of COPC. Title V of the ACA provides funding for health promotion among underserved areas through using community health workers. This title also allocates funding to train community health workers on the needs of underserved areas and educating primary care providers. Moreover, the ACA created the fundamental shift in healthcare to incentivizing population health rather than individual patient health through the creation of accountable care organizations. Therefore, the ACA provides the framework and funding for the implementation of COPC.
In order to implement community-oriented primary care in the U.S. healthcare system, healthcare leaders will need to work to redefine and reorganize the way the U.S. healthcare system functions. There are several barriers to implementing community-oriented primary care. One central issue is that the U.S. healthcare system was foundationally centered around fee-for-service financing and is a demand-based system of primary care rather than a value-based financing system. The healthcare system has also always been focused on providing care for sick individuals rather than focusing on prevention and the health of an overall population, and as a result, there is a fragmentation of services that will need to be consolidated in order to move towards community-oriented care. These issues all need to be addressed in order to focus more on community health rather than individual health. Community-oriented primary care has created a unique merger of 2 fields, public health and primary care. COPC is actually a blend of these 2 fields. It has borrowed from public health ideals of prevention, early intervention, and health promotion, and has worked towards integrating that with primary care to improve overall population health. It is argued that practitioners must have a broad view of the overall health of a population that an individual belongs to in order to treat the patient holistically. The core value of COPC is community involvement. This shifts healthcare from a more hierarchical model to a more democratic model. Patients get to participate in healthcare decision-making, therefore, care is directed at the actual needs of a community rather than their assumed needs. These are all values of public health that are vitally important to the success of COPC. Community-oriented primary care is a practical approach to healthcare. There are several benefits of this form of healthcare, including community participation in healthcare, where the consumer may participate in healthcare decision-making, easier access for communities to holistic healthcare, rather than fragmented care services. They are now all available in one place through COPC. COPC is also catered towards the needs of each community, so it works towards reducing healthcare disparities. And COPC organizes healthcare around the needs of the entire community, so necessary healthcare is available to those who need it. COPC also raises the integrity of practitioners who are operating under a value-based pay system rather than volume-based pay systems.
An example of community-oriented primary care in the U.S. takes place in Dallas County, Texas. Dallas County holds the largest urban application of COPC, and the COPC services took place in the Parkland Health and Hospital System, one of the largest publicly funded teaching hospitals and healthcare systems in the U.S. Parkland implemented its COPC programming during a large demographic shift characterized by a 200,000 person population growth from 1990 to 2000, as well as a jump in the county's Hispanic population growing 110% to take the Hispanic population percentage up to 30% of the total population. On top of this, an economic boom in the late 1990s led to low unemployment rates. Despite all of this growth, Parkland still saw double the percent of uninsured patients than among the general population. Dallas County based their COPC program around 6 key elements: assessment of community needs and assets, community prioritization of healthcare issues, collaboration with community organizations, provision of primary healthcare, evaluating, and financing. Ultimately, the Parkland COPC model was based in linking primary care with specialty and inpatient services, maintaining active community engagement through forums and advisory boards that established healthcare priorities, and collaborative partnerships between community members and healthcare professionals that discussed the health and safety in their neighborhoods. The future of community-oriented primary care is dependent on collaboration between community clinics and academic health centers. Some academics believe that COPC training networks need to be established, the kind that cluster community clinics and bring in academic health centers to conduct research on each community clinic. In the same vein, COPC can be extended to rural areas through networks of collaboration. Others see a multifaceted future to COPC. Some believe that COPC is a strict prescription of tenets that only when applied exactly as stated will yield positive results. Others see the future of COPC in an attitude-based approach where an engaged community spirit is the simple solution. Some see the future of COPC in the classroom, in teaching COPC values in clinical practices, medical schools, residency programs, and graduate schools of medicine, nursing, and public health. Graduates will move into the healthcare field already prepared to handle primary care with COPC values. In addition, COPC values are hypothesized to be highly beneficial in current healthcare issues, such as providing care to traditionally underserved communities and populations by promoting citizen engagement and educating on the importance of primary care. In closing, our 2 discussion questions are: do you think community-oriented primary care has a valuable impact on primary care? Do you think it is a tactful guide to community care approaches? Or do you think it falls closer along the lines of an idealistic theoretical framework? And second, do you think the current administration's policies on healthcare and recent repeal of the Affordable Care Act will impact community-oriented primary care approaches, and if so, in what ways? Thank you so much.